Assalamu alaikum. My name is Hala Zafar and my roll number is EP1770049. And my topic of presentation is endocarditis. While my subtopic of presentation is endocarditis caused by Staphylococcus aureus. So we're going to begin with the introduction of our topic, that is infective endocarditis by Staphylococcus aureus. So it has been majorly reviewed as a community-acquired disease. Patients with implanted medical devices like grafts and pacemakers are at higher risk of developing this infection by Staphylococcus aureus. So we're gonna do now the case study. So we have a 36-year-old male who's immunodeficient virus, seropositive man with a long history of IV drug abuse. He was admitted in the hospital for months after being released from the straight prison. His complaints were like fever, night sweats, chest pain, shortness of breath, fatigue. Physical examination shows that his body temperature was 101.2 degree Fahrenheit. And his laboratory results showed that his WBC count was 14,000 per mm cube with 65% bullies and 5% mans. His CD4 cell count was 350 per mm cube. His hemoglobin was 13.1 grams per deciliter. His blood cultures came all positive for cocci, gram-positive cocci, and later it was identified as a methicillin sensitive as Staphylococcus aureus. So now we have to discuss two things that are like, how do the clinical presentation and prognosis of endocarditis in the IV drug abuser differ from the non-abuser? What impacts does HIV infection have on the risk and outcomes of endocarditis in the IV drug abusers? So for the patient, treatment choice is methicillin. Methicillin is the first choice of drug in endocarditis caused by Staphylococcus. But our patient is methicillin sensitive Staphylococcus aureus positive. So we cannot give him methicillin. So the other drug choice for this is penicillinase resistant penicillin, which is Methicillin or oxacillin. So it was done in a clinical trial that 4 to 6 weeks of therapy with high dose of like about 12 grams per day Methicillin is effective in these kind of patients. Now we're going to move forward to the treatment choice of addicts with uncomplicated right-sided endocarditis. Addicts with uncomplicated right-sided endocarditis that is caused by MSSA, can be treated successfully with 2-week course of combinational therapy with penicillinase-resistant penicillin and aminoglycosides. So treatment with the combination of IV Methicillin, that is about 1.5 grams Q 4 hours, and tobramycin, that is about 1 grams per kg Q 8 hours, for a total of 2 weeks. Another treatment that can be given is of 2 weeks course of cloxacillin, that is 2 grams IV Q 4 hours, plus amikacin, that is about 7.5 milligrams per kg IV Q 12 hours. Now we're going to talk about oral regimens for addicts. So the first oral regimen that we give is ciprofloxacin, that is about 750 mg Q12R, plus rifampin, that is about 300 mg Q12Rs. And ciprofloxacin is given at IV, that is 300 mg, for 7 days, and followed by oral administration of 750 mg Q12R for the remaining 21 days of therapy. Treatment choice for penicillin allergic patients. So many patients are like allergic to penicillin, so we have to find alternatives for them. So the first generation cephalosporins have been used in the treatment with mild penicillin allergy. Many drugs fail in treating patients with penicillin allergy, so we use vancomycin to treat patients with endocarditis caused by Staphylococcus aureus who have intermediate type hypersensitivity to penicillin. Other options include linezolid and daptomycin. We can also use combinational therapy. Combinational therapy consists of methicillin and gentamicin, resulting in more rapid clearing of the organism from the blood, but the response rate is similar to patient treated with methicillin alone. So now we're going to discuss methicillin-resistant Staphylococcus aureus. So Staphylococcus aureus involved methicillin-resistant strain. Um, accounts up to 40% of the cases. Mostly it's present in 40% of the cases. And these patients have more chronic conditions like diabetes or hemodialysis dependency and are more likely to have health care associated infection. They have like intravenous catheters. So the treatment of choice for the MRSA, we have vancomycin, and vancomycin is given about 30 mg per kg per day in two divided doses for a total of 2 to 4 weeks with patients that have normal renal function. Now we're going to discuss other therapeutic options like trimethoprim sulfamethoxazole, which is used for right-sided native valve endocarditis, aminocycline, that is for MRSA, and linzoid, that is not FDA approved. And the alternative for TJ's treatment, we can give daptomycin for Staphylococcus aureus bacterium and right-sided endocarditis, which is about 6 mg per kg per day. So I would like to conclude my presentation here. Thank you so much for listening.